Good evening to one and all present. On behalf of the whole WBA CTVA community, I feel privileged to welcome everyone to the second and final day of the annual conference of IACTA West Bengal. I would like to thank Dr. Peter Slinger, Dr. Annette Vegas ma'am, who are joining us live from Canada, Dr. Amish Jaspara and Dr. Suresh Rao to take out time from their busy schedule and part of this conference. Now I would like to ask Dr. Somi to start the proceedings for today's program. We are not able to hear you, Dr. Somi.
Okay, am I audible now?
Yes, yes, yes.
Okay, thank you, Dr. Verma, for introducing all the eminent speakers who are present today. Good evening and warm regards to all. Given the very strange times we are going through, a good old 19 months into the pandemic, we have seen some real tragedies. So in this context, I would like to quote, before I begin the session, something which the famous Michelle Obama has said: "Courage can be contagious, and hope can take a life of its own." So with this, we begin our program today. The theme for today is surgery for advanced heart and lung failure and the cardiac anesthesiologist. The opening lecture is, the topic is perioperative challenges in heart transplant. And I would like to call in the chairperson for the session, Professor Shompa Dattagupta, who is head of the Department of Cardiac Anesthesia, NRS Medical College, to kindly introduce our speaker and open the session. Dr. Shompa, are you there?
Yes. Am I audible?
Yes, you are.
Yes. I'm going to start my video. What is the problem? Hello. Very good evening, everyone. First of all, I want to express my deep gratitude to the organizing committee for inviting me to be present here. First of all, I want to congratulate the IACTAWB for this successful conference yesterday. And to start with, the organizing committee nicely said for today's first topic on perioperative challenges in heart transplantation. In recognition that heart transplantation represents the unique challenges for general anesthesia, critical aspects of intensive care management, the importance of initial postoperative management, and the need of very careful, broad, and detailed monitoring of heart and distal organ functions, and early therapies to reduce the postoperative complications that impacts on allograft survival and patient outcome. For this discussion, I like to invite Dr. Amish Jaspara, who is the Senior Consultant Cardiac Anesthesiologist of Fortis Hospital, Mulund, Mumbai. Anesthesia for heart failure surgeries and transplantation is a special area of interest. He has one national and one international publication. I'd like to invite Dr. Amish Jaspara to start the session.
Yeah, so am I audible?
Yes.
Yes. So I'd like to share my screen. Yeah. So is it seen now?
Yes.
Yeah. So thank you very much for a very warm introduction. And I would like to thank the West Bengal IACTA for giving me a chance to speak on this topic. And greetings from Mumbai to all the eminent speakers and all the delegates. So my topic for today is perioperative challenges in heart transplant, and I will be discussing the whole topic under these following heads. Okay. So coming to the first etiology, if you see over the last 30 to 40 years, the incidence of the main causes of end-stage heart failure have been ischemic as well as non-ischemic heart failure. And in the last 10 years, the non-ischemic cardiomyopathy has overtaken ischemic cardiomyopathy. The main causes been listed here, such as viral myocarditis, peripartum cardiomyopathy, which is quite common, tachycardia-induced cardiomyopathy. We had one such case of tachycardia-induced cardiomyopathy. So having known the etiology, we transplant these patients when they come in cardiogenic shock requiring continuous IV inotropic support or mechanical circulatory support. When these patients develop NYHA class 4 symptoms, which are refractory to any form of medical therapy, intractable or severe angina symptoms in patients with severe coronary artery disease, which are not amenable to percutaneous or surgical revascularization. In fact, in Western countries and not even in, and even in Leipzig, where I have done my fellowship from, these patients, they undergo directly LVAD implantation, and then they are bridged to transplant depending on the organ recovery. And intractable life-threatening arrhythmias, which are unresponsive to medical therapy. So these are the kinds of heart that come for transplantation. Here is an example of dilated cardiomyopathy, where you see biventricular dilatation. Here you see a restrictive cardiomyopathy, where the ventricular contractility is quite okay, and the ventricles are very small with severe biatrial dilatation. These patients mainly come with symptoms of diastolic heart failure or heart failure with preserved ejection fraction. And this is a classical case of hypertrophic cardiomyopathy with hypertrophied septum and anterior and posterior walls. So can we transplant all the patients that come to us with end-stage heart disease? The answer is no. There are some absolute contraindications, such as irreversible PH, which is defined as systolic pulmonary artery pressure more than 60 mm of mercury, TPG more than 12, that is a transpulmonary gradient, and a PVR of more than 4 Wood units. We will discuss this later in the coming slides. Systemic illness with life expectancy less than 2 years, such as solid organ and blood malignancies, HIV disease. Coming to the relative contraindications, age is a very dynamic factor, with both in India as well as Western countries, more and more people of older age are now getting transplant. Severe and symptomatic peripheral vascular disease, cerebral vascular disease, diabetes with end organ damage, where combined transplantations have to be undertaken. We have done such one combined liver and heart transplantation, morbid obesity, COPD, mental illness, active infection, and addictions. So now coming to the donor management. So our transplant planning begins with this WhatsApp message sent by the transplant coordinator on this WhatsApp group, where the donor location, the age, the sex, the weight of the patient, the cause of brain death, number of days on ventilator, and all other details such as a contact person has been given to us. And from this initial data only, we realized that it is quite far. It is in Gujarat, Ahmedabad, which is quite almost 500 kilometers from Mumbai. The donor is not a traditional donor. Does not fit the traditional criteria. She is a 53-year-old, has a history of cerebrovascular stroke. So when we contacted the intensivist there, she said that it was a hypertensive bleed, and this patient is suffering also from diabetes. We asked for all the biochemical investigations, a monitor PIC and echo loops to see what is the current state of the patient. And if you see the monitor, you can realize that the donor has been managed without an arterial line. And if you see the echo, you see a very poor biventricular function. There are hardly any, maybe just EF of around 25-30%. And so what do you do now? So if you see the input-output chart, you can see that the hemodynamics are haywire. Heart rate is 150, pressures are about 200. This can happen in catecholamine due to catecholamine surge, but the patient is also receiving very high doses of noradrenaline at around 20 ml per hour and vasopressin at 6 units. We know that more than 2.4 units does not help. Sugars are haywire. It is receiving large volume of 5% dextrose for volume expansion. And that is the main reason why the donor, why we have such a bad donor hemodynamics. So before I go into what we did with this patient, I would broadly like to, in short, discuss the donor management, and that we should always establish appropriate monitoring. Invasive blood pressure, mainly radial artery is preferred, because if there is a femoral line, this can interfere when the liver people are also handling the abdominal aorta. Crystallized with balanced salt solution are preferred. And noradrenaline and vasopressin can be used, but they should not be used at a very high dose because they increase the afterload so much that there is consequent myocardial ischemia, which is not good. Just like any other cardiac surgery, we need to correct all the metabolite and electrolytes, especially the potassium, temperature management, infection management. We collect all the blood cultures and bring it to our institute where they are analyzed, and the donor and the further antibiotic is according to the culture reports. As far as the hormonal resuscitation is concerned, IV thyroxine is still not available in our part of the country. So, and we have, frankly speaking, we have still not used the oral thyroxine. Steroids we have never used in heart transplant, but they say in the lung transplant, a single dose of methylprednisolone in donor is helpful. A coronary angiogram should be done if the patient has if the patient is more than 45 years and has comorbidities. And all this management has to be very meticulous and sophisticated, especially when now we have started accepting organ donors from extended donor criteria, such as age more than 60, non-obstructive coronary artery disease, post-CPR patients, low LVEF patients, LVH, not a big problem in India, normal functioning bicuspid aortic valve, and patients with on high inotropic support. So coming back to our patient, when we did the transesophageal echocardiography, you see there is a lot of poor LV contact, and there is a lot of low flow state and dilated and sick in the right side of the heart as well as on the left side of the heart. Our HOD, Dr. Vijay Shetty, had himself gone to optimize this patient. He optimized over 6 hours. The hypotonic fluids was balanced, all solutions was started a small dose of dobutamine. Glucose control was taken. Frequent AVGs were done, and you can see the time 1 a.m. after almost 6 hours of resuscitation, we got this result. So this organ had, so this was quite good contractility, and this patient then underwent a coronary angiogram, which was normal, and we accepted this heart. And remember, the same principles of ICU management have to be followed in the OT till the organs are harvested. Now, coming to the recipient, there are two types of recipients. One are the stable patients and one are the critically ill patients. The stable patients get admitted in wards during the transplant workup, and that is the time when we visit them. We ask them a thorough clinical history, fluid episodes of fluid retention, hospitalization, their effort tolerance, and do a thorough examination, look for pedal edema, do an airway examination because in emergency there won't be much time. All the medications are reviewed. Substance abuse cessation is advised, and always we prefer to do a bedside echo, and a vascular scan is most important because if these patients come in decompensated state, we have to put them into MCS, and if we know the size of the vessels, we can plan our MCS strategy quite well. The other subset of the patients, that is the critically ill patients, these patients are referred from other hospital after a cardiac procedure, mainly CABG from in our city, or our own listed patients who come with acute decompensated heart failure. And the transfer of these patients is very challenging. You can see in this one ambulance, we are transferring a patient with an IVP and an ECMO. So all the battery backups have to be ready and hemodynamic management has to be very fine. You should see all the infusion pumps with all your supports are working well. And we transfer usually during the night because morning time there is a lot of traffic in Mumbai. Now coming to the next important investigation, that is the right heart catheterization. This is the most important investigation which will determine the candidacy of the recipient to for heart transplantation. Here what we do is we measure pressures on the right side of the heart, the RA, RV, PA, mean PA, PCWP, the transpulmonary gradient, that is the mean pulmonary artery pressure minus the PCWP, the PVR, then the cardiac output. So if you see in this case, the TPG is around 2 millimeters of mercury and a PVR is 1 Wood unit. So this patient is good, does not have any intrinsic pulmonary vascular disease and can be easily transplanted. But that is not the picture every time. If there are many patients who come with high TPG and high PVR, so what do we do in these patients? So let's see one example. This is one of our patients who underwent catheterization. At first admission, when we did the RHC, the CVP was around 20, the PA systolic was 70, TPG was 16, and PVR was 5.10. Naturally, we cannot transplant this patient, otherwise he will die of right ventricular failure. So what we did, we gave him home milrinone and oral Lasix. And after 1 month, when we did the TPG, we did the right heart, the CVP had come down to 4, the PA had improved, the TPG had come down to 14, the PVR was 3.8. So we know that this is reversible PH and this patient can be safely listed for transplant. Other agents which can be used are inhaled nitric oxide and IV sildenafil. Now, in the critically ill subset of the patients, there is no time to do any such investigation. And these patients, they come in cardiogenic shock, and we have to just institute mechanical circulatory support in these patients. And the aim of all this is to offload the heart and protect the other organs for transplant. You see, in all these 3 patients, we have inserted non-durable LVADs using a Centrimac pump. So with this, I would like to share our experience of mechanical circulatory support from our institute, where we have instilled 41 cases of MCS over a period of 4 years, both pre and post transplant. Majority of cases have been VA ECMO, followed by IABP, LVAD, all non-durable LVADs. RVAD, 2 cases which were post transplant, both did well, and COGI VAD, that is a VAD with an oxygenator. Coming to the next important investigation which will influence the outcome of the transplant is the HLA antibody testing. The first test what we do is the panel reactive antibody testing. Here the recipient serum is tested for antibodies against a panel of lymphocytes from the approximately 100 donors from the local population. At first we get a qualitative report whether it is negative or positive. If it's negative, there is no issue, patient is non-sensitized. But if it is positive, then we ask for how much percentage it is positive, and any patient with PRA of more than 10 to 20% is said to be allosensitized. So coming to these sensitized patients, if you see over the last 20, in fact, from 1998 to 10,000, this is a quite old paper, you see the incidence, the number of non-sensitized patients has been gradually decreasing as well, and the burden of the sensitized patients has been gradually increasing. The main reasons for these are the VADs, the blood and blood product transfusion, and the pregnancy. Now, what all these things lead to? It leads to further immunological testing, which HLA phenotyping, increasing wait times to transplant, increased risk of rejection, and cardiac allograft vasculopathy, and patient requires desensitizing therapies such as plasmapheresis and IVIG. And what happens with this is that it negatively impacts the outcome of the transplant as well as increases the cost of the transplant. So we had one patient with 94% PRA positive. So what we managed this. So what we did in this case was we repeated PRA after 2 months, which had come down to 22%. Luckily, the patient stayed in a compensated state, was medically managed. We planned that we will select a within city donor for this patient, where we can do prospective cross matching to determine the donor specific antigen. And when we had an appropriate donor, we did plasmapheresis before the induction of anesthesia, gave him a single dose of ATG in the post-operative period. Normally, we start tapering steroids from day 1, but in this case, we delayed up to 3 to 4 days once the patient was extubated and had good biventricular contractility. So coming to the non-hemodynamic recipient optimization is same as any other cardiac surgery. Coming to the hemodynamic sensitization, we give diuretics, fluid restriction, ACE inhibitors, and ARNI if they are tolerated. The whole aim being to offload the heart. Beta blockers are given to decrease the workload, and we have to prevent any electrolyte imbalance or any other factors which can push them into a decompensated state. The whole aim being to keep the recipient as dry as possible and crisp for transplant. So coming to the perioperative anesthesia challenges. So on the day of transplant, a reassessment of the patient is done. Majority of these patients have developed fluid retention and weight gain. So we diurese them. We get around 5 to 6 hours before the patient wheels into the OT. So during that period, we diurese these patients. We resend all the investigation. We always do a repeat vascular scan because these patients have a high incidence of developing thrombosis. And it is always better to know beforehand rather than having any surprises at the time of cannulation when every minute matters. We have never faced a full stomach till now because, as I said, 5 to 6 hours goes in all the logistic mobilization and all those things, and adequate blood and blood products are kept reserved. So all these patients have pacemaker and CRT. Majority of these patients have pacemakers and CRT devices. So they should be reprogrammed to a mode that will not interfere with electrocautery. External electrode pad should be applied, and this can interfere with our venous cannulations also. Now coming to the another most important step is the donor recipient matching. Now the allocation is done on the recipient priority on the waiting list. Now patients with mechanical circulatory support are always escalated on the list, and the allocation also depends upon the geographic location from the recipient. We receive majority of our donors from interior of Maharashtra or Gujarat, but we have traveled up to Visakhapatnam for getting the donors. In that case, we knew the ischemia time would increase, but the donor was just 17 years old, road traffic accident with normal LV function, so we thought of taking a chance, and we were quite lucky in that case. The matching is done depending upon the AVO blood group, a body size compatibility, that is plus minus 20% of body weight is accepted. Nowadays, we can also use the predicted heart mass, that is the LV mass as well as the RV mass. Calculations of these are easily available on the internet, and donor body mass, heart mass divided by the recipient predicted heart mass. If it is less than 0.86, such transplant should not be done. Oversizing as well as undersizing should be prevented, because both of them, they have their disadvantages. We maintain a gender concordance. We never transplant a female organ into a male because these patients tend to have primary graft dysfunction in the post-operative period. And if the patient is allosensitized, then the matching is done only if there is negative DSA. Now, the timing of induction and incision, coming to that, there should be always an optimal communication between the donor and the recipient team. The preparations are started once the donor team initially evaluates the status of the recipient, the hemodynamic status. Once the patient is wheeled in, the heart is visualized and manually palpated, and once the final acceptance is given, the recipient is taken into the operating rooms. Now, special consideration should be given when there are multiple harvest teams coming from different geographical locations. If the recipient is reduced sternotomy, because this may take time, or if the patient has mechanical circulatory support. Now, the most important event during all this is the aortic cross clamp time, and this should be clearly communicated before applying it, because if the recipient team is lagging, then the clamp needs to be delayed, or if the donor is becoming unstable, then the recipient team needs to hurry up. And all these optimal communication and time constraints are present if the donor and the recipient are in the same city. This is just an example of how we communicate with each other during the harvest. You can see the clamp time is put, what time we left from the hospital, we share our location. So it becomes easier for each and every person to know what exactly is happening. And all these efforts are done to always to keep the ischemia time under 4 hours, because if you see that the survival at 6 years is more in patients with ischemia time less than 4 hours. Rejection at 1 year is less, again in the same set of patients, and the length of hospital stay is also less in patients with ischemia time less than 4 hours. So it has both long-term as well as short-term benefits. Now, the induction of anesthesia, all invasive monitoring lines should be done under local anesthesia and always under USG guidance. And in patients with VADS, arterial line is very challenging because there are no pulsations in these patients. Pendulum position should be avoided. Slight propped up position is preferred. All efforts should be done to keep the patient calm and anxiety free. Our choice of anesthesia is intermediate fentanyl and rocuronium. We start inotropes and vasopressors in minimal doses before induction, because these are dependent on endogenous catecholamines, and abolishing the sympathetic drive will lead to a collapse. We post the PA catheter after the induction and to measure the values, but one should remember to always withdraw it up to 10 Mach, otherwise it will get cut during the surgery. And RV protective and PVR reducing ventilatory strategy should be applied. At all costs, the whole aim of induction is to prevent any kind of cardiovascular collapse and to maintain preload, afterload, and contractility. What you see in picture B, the hemodynamics at all costs should be avoided. Now, coming to the immunosuppression and antibiotic management, our choice is steroids. we give in a dose of 500 milligrams methylprednisolone at the time of induction of anesthesia, and 250 milligrams before the release of cross clamp is given by the perfusionist. IL-2 receptor antagonist basiliximab is the most common drug used in our institute, and advantage of using it is that it helps in preventing any acute rejections on table, as well as it helps in delaying the initiation of tacrolimus. Antibiotics are according to the donor cultures, and tranexamic acid is also given. So this is the hemodynamics this is the monitoring which we use. We put both radial as well as femoral lines because to avoid any discrepancy in the post-operative period. The PA pressures, CVP, advanced hemodynamic monitoring with continuous cardiac output, PVR, SVR, SVO2 is done. We now very well know that cerebral oximetry has been a surrogate marker of proper tissue oxygenation and cardiac output. So it is very useful. And lastly, we use BIS because these patients are at high risk of awareness. So this is just an example of how we put the cerebral oximetry leads and the BIS lead on the forehead of the patient. I just wanted to mention about these RV pressure monitoring ports. These are specialized pulmonary artery catheters which I had used during the fellowship days, and it has an RV pressure monitoring port where you can simultaneously measure the RV pressure also along with PA, CVP, and arterial blood pressure. I'm quite sure, and it helps. It is in fine-tuning your your RV dysfunction management. These are not available in India. We try to procure them, but somehow we're not able to do it. Key in the pre-CPP period is not of much value. We just need to look for any thrombus, pleural effusion, atheromatous disease. It may help in guiding the cannulations in redo cases. Most important is any congenital abnormalities such as dilated coronary sinus because or the presence of left SVC, because this may alter the surgical plan. Now coming to the surgical procedure per se, there are two types of transplants, the orthotopic as well as the heterotopic. Heterotopic is no longer been advocated, especially after the advent of the VADs. Among these two, the bicaval is the most common method. Here we do recipient cardiectomy at the level of SVC, IVC, aorta, PA, and the posterior wall of the LA is cut in a rectangular fashion such that the openings of 4 pulmonary veins are preserved. Then the heart is the recipient cardiectomy is done, and this is what the empty pericardium looks like. One should always do a meticulous hemostasis during this period because once the transplant is done, this region won't be accessible. This is just a small video of a heart transplant. Here you see the recipient cuff, the recipient LA cuff. This is the donor heart. The surgeon will now cut on the posterior wall of the LA between the pulmonary veins and will prepare a donor LA cuff. So this is the trimming. You see a good donor LA cuff. Now you can see the mitral valve below, and this will be anastomosed. This is followed by the IVC anastomosis. This is the IVC anastomosis. Here you see the IVC cannula and the donor IVC, which are then done. This is followed by the SVC anastomosis. You see the central line here, and following this anastomosis, the region between the aorta and the PA is inside, and the pulmonary artery is cut at the level of bifurcation such that 2 stumps of pulmonary artery and aorta, this is the PA, this is the aorta, and the anastomosis is completed following the end of the transplantation. So this is the usual order we follow for transplantation, but whenever the ischemic time exceeds 4 hours, we just do the LA cuff, the IVC, the aorta, and release the clamp, and the PA and the SVC can be done later on the beating heart. Now, once the patient is ready, thorough de-airing from LV should be done from all the anastomotic sites and LV apex. Adequate rest period, we give around 1 hour. AV sequential pacing with higher rate because RV requires that. Small doses of adrenaline, noradrenaline, milrinone are started. Ventilatory strategies, again, same to reduce the PVR. Nitric oxide is started at 10 to 20 parts per billion ppm. Once the SVC cannula is removed, the PA catheter is floated under TE guidance, and at times with the help of the surgeon if it does not go. And when everybody is ready, the slow and careful feeling of the heart is done under visual and TE guidance, and the patient is gradually weaned off CPV. So these are the optimal hemodynamics which we would like to have. The mean map above 75, above 60, mean pulmonary less than 25 CBP on the lower side, a good cerebral oximetry. You see a gradual rise in the cerebral oximetry from a baseline value and a good cardiac output along with the PVR and SVR. Coming to the
Dr. Amish, I'm sorry to interrupt. You will have 5 more minutes.
Yeah, I'll just try and finish it as fast as possible. The T in the post-CVP period is very challenging. You look for the integrity of all the anastomosis as well as the examine all the valves. Now coming to the most common valvular abnormality is the tricuspid regurgitation. We have had cases of tricuspid regurgitation, but we have never repaired them. And while doing a net search, I found a study where they studied the implication of untreated TR on long-term outcomes, and they found that at the end of 1 year, 91% of the patients had insignificant, had resolved TR. So this is one case of SVC stenosis which was detected by TE. Here you can see post-anastomosis, there is no flow here, and this is the site of turbulence. And this also shows a very high gradient. This was informed to the surgeon. The anastomosis was revived, was redone, and we had a phasic flow followed. The posterior wall of the LA anastomosis looks like a ridge, which should not be mistaken as a thrombus. And any presence of hemodynamic stenosis should be ruled out because this may lead to RV failure. Coming to the last part, we all know RV dysfunction causes high PVR, longer ischemic time, clinically failure to wean off CPV, over-distended and poorly contracting RV. Management till now as cardiac anesthesiologists, we all know the management about the RV dysfunction is to maintain the heart rate, optimize preload, reduce afterload, and maintain the contractility. And when all these measures fail, you keep the chest open and install mechanical circulatory support. This is just an example of how poor the RV contractility is. And once the milrinone and nitric oxide goes, you can see quite good contractility. The other treated complication is primary graft dysfunction, which has a very high incidence, almost up to 30 to 40% in the first in the first 30 days. Causes being improper donor management, reperfusion injury, unrestricted use of blood and blood products reaction. Management again is the same: inotropes, inodilators, vasopressors, and MCS. So this is an example of LV PGD. You see hardly contracting LV. We gave ECMO support. After 3 days of ECMO, the patient had quite good LV contractility. Coming to the RV PGD, you can see this is a very poorly contracting RV with a D-shaped septum. Gave RVAD to this patient, and this patient had quite good after had quite good contractility, and he recovered after 5 days of RVAD. Bleeding is same as any cardiac surgery, which is guided by ROTEM guided blood and blood product administration. Coming to the post-operative care, again, RV early extubation, step-up immunosuppression, stick infection, diuresis, early mobilization, and physiotherapy. Coming to the non-transplant surgery, these patients are preload dependent. They will not respond to adrenaline, atropine, so you require to have adrenaline and non-adrenaline milrinone. They are prone to coronary artery disease, and general anesthesia is generally preferred. And in present times, no webinar is incomplete without the mention of implications of COVID-19. So what ISHLT recommends does not recommend complete cessation of cardiothoracic transplantations. So if the donor is RT-PCR positive, then it straight away decline the donor. If he is more than 21 days with complete resolution with a negative RT-PCR, you can accept. Coming on the recipient side, if the RT-PCR is positive, you delist the patient. Of course, there is a high risk of mortality. And if the recipient is more than 21 days with a negative RT-PCR and complete clinical resolution, you can go ahead with the transplant. So I would like to end this this presentation with a note saying that transplant is a gold standard for all end-stage heart disease, and with good teamwork and all these challenges can be easily met, improving the patient outcomes. Thank you very much.
Thank you, Dr. Ramesh. Dr. Amish has reviewed very nicely the important insights of anesthetic consideration, including the hemodynamic management, immunosuppression, and the managing susceptibility to infection. He also discussed nicely the signs of rejections and added the active non-cardiac surgery plan that should be, he also mentioned that should be postponed in case of signs of rejection. I think there is no question. So thank you very much, Dr. Amish. With this, I am ending this session. Thank you, Shomi.
We can invite questions though from the audience. If they have any, please go ahead. You can ask our expert.
I think there is no such.
There is nothing in the chat box.
Yeah.
So I guess there is no question. Dr. Ramesh,
Yes.
if you could
Yeah.
unshare your screen, please.
Thank you very much, Dr. Das.
Thank you, Dr. Ramesh. Thank you for that wonderful sharing your experience with us. So the next topic is a didactic lecture on perioperatives in lung transplant. And we have a very eminent speaker of international repute with us today to speak on the same. And I would ask Dr. Shoykot Sengupta, who is a chairperson for this session. He's a senior anesthesiologist, consultant and academic coordinator, Department of Anesthesiology, Apollo Gleneagles, Kolkata. And I would ask him to kindly introduce our speaker and begin the session.
Thank you, Shomi, and good evening to everybody. And I hope I am visible and audible. I can already see Pete smiling to us from his, I don't know whether it's his office or his home way in Toronto. Welcome, Dr. Peter Slinger. I just can't help but addressing him as Pete. Anyway, Dr. Peter Slinger is a professor of anesthesia and a consultant at the Toronto General Hospital in Ontario, Canada. He is also the chair of the CPD Educational Committee of the University of Toronto. I think he actually needs no introduction to many of us in this part of the woods. He has been a frequent visitor at the Indian Association of Cardiothoracic Anesthesia meetings, as well as the Indian Society of Anesthesiology meetings several times. And we have had the pleasure of interacting with him during the workshops on thoracic anesthesia, and as well as his talks and deliberations. A lot of us grew up with what we know as Kaplan's thoracic anesthesia, where he has been an editor for several years, and now he's also the chief editor of the book to go to for anything regarding thoracic anesthesia, the principles and practice of thoracic surgery. So it's my pleasure to introduce one of the people whom I look forward to, whom I look up to for anything related to anesthesia, personal as well as professional in thoracic anesthesia. Thank you, Pete, for joining us, and welcome to this meeting of the West Bengal Society of Cardiothoracic and Vascular Anesthesia.
Thank you very much, Nivedita. And I'd like to thank Dr. Das and Dr. Biswas for the kind invitation to give a lecture, and also for managing to resurrect this meeting, I guess, if that term is okay, that I know you had to postpone it. And I'm very happy that you've been able to get it on board. Now, I'm going to see if I can share my screen with you. Let's see. I'll get my, see if I can get my slides up here. Now.
Yeah, they are visible as slides, sort of, Pete.
Okay.
Yeah, good to go.
So I'd like to talk to you about an update in management of anesthesia for lung transplantation. We'll follow this patient, a 65-year-old woman, that's her x-ray on the left, with pulmonary fibrosis through the process. And I'd like to concentrate mostly on some relatively current developments in anesthesia for lung transplantation. I'll explain to you about ex vivo lung perfusion, and the increasing use of extracorporeal membrane oxygenation, ECMO. We'll talk about standard things for all patients having lung transplantation, about airway management, the anesthetic, monitoring fluids. And then I'll finish talking a little bit about the differences in how we modify our anesthetic management, depending on the underlying disease of the donor. Now, the hospital where I work, the Toronto General Hospital, the lung transplant program began in 1983. And since that time, they've performed over 2,000 transplants. The graph shows the distribution of bilateral versus single. As you can see, about almost more than 90% of our transplants are bilateral or double lung transplants. And occasionally a heart-lung transplant, and very rarely something combined like a lung-liver transplant. These are our indications for lung transplantation over the period of the program. The large green segment of the pie, that's interstitial lung disease, pulmonary fibrosis. The number 2 indication, the blue, is obstructive lung disease, COPD, emphysema. We have a fairly large third indication, and that's cystic fibrosis. I don't know if you see much cystic fibrosis in your population. And then the 4th and smallest in red is primary pulmonary hypertension. And then there are a variety of other kind of orphan lung diseases that occasionally require transplantation. So start beginning talking about the donor for this patient. The donor is a 55-year-old man in a peripheral hospital who's had an intracerebral hemorrhage. He's a non-smoker, and when they contacted our hospital saying they had a potential donor, the PaO2, FiO2 ratio was 400. Patients obviously unconscious on a ventilator. Now, by the time the retrieval team gets to the peripheral hospital, the oxygenation has deteriorated, and the PaO2, FiO2 ratio is now 200, which is under what we would say is acceptable, minimum being at least 250. Now, 15 years ago, those lungs would have just gone in the garbage. The retrieval team would have just come back and we'd have to look for another donor. Now they bring these lungs back, these marginal lungs, and we will do what we call ex vivo lung perfusion. And here you see it. We're actually ventilating these lungs, and we've hooked them up to a modified cardiopulmonary bypass circuit, and we're perfusing them. And then over a period of about 4 hours, we'll try to improve the gas exchange in those lungs. You see these lungs are not pretty. However, patients lived in a city, but about half the time, we can get these lungs to an acceptable gas exchange over a period of 4 hours. And then we can transplant these lungs. Now, is there any danger to this? Well, very few people have actually studied this, but this was one study looking at over 300 lung transplants where they actually routinely in a group of patients did this EVLP, this ex vivo lung perfusion. And what they found, as you can see in yellow, that they actually, in the patients who had received the ex vivo perfusion, primary graft dysfunction was decreased significantly. However, there was no difference in overall survival or 1-year survival, which is good because what that means is these lungs are not worse, okay? They may not be better than lungs that haven't had this done, but they're not worse, and they're lungs that we can now use that we didn't have before. Now, this graph, EVLP was first introduced 12 years ago at our hospital. And you see on the far left, those bars, 2008, perhaps 4 out of 85 lung transplants that year had EVLP. And it's progressed to we don't have complete data for 2000, but here on this slide, for 2019, the blue bar there at the top, the blue portion of it are lungs that had EVLP, and the purple part at the bottom is lungs that do not. And as you can see, about a third of our lungs now that we use have had EVLP. So this represents a third of the transplants that we do now. 15 years ago, we couldn't do these transplants without EVLP. So this has been a big increase in our availability of donors. So here's our patient, 65-year-old woman. She's 153 centimeters, 60 kilos. She's on oxygen, prednisone, OFEV, which is a therapy for pulmonary fibrosis, and some puffers. Here's some of her investigations. She's got restrictive lung disease, as we would expect. FEV 133%, DLCO 28%. A VQ scan shows the better perfusion on the left. So we'll start with the right lung. If we're going to try and do this without ECMO or support, her blood gas is normal. So this is reassuring. It's always, as I'll explain, very important to look for patients who are either hyperventilators or hypoventilators before induction of anesthesia to guide your anesthetic management. Preoperative transthoracic echo shows normal LV function, some right ventricular hypertrophy, and an RVSP of 36. Now, this is a patient being positioned for bilateral double lung transplant, arms out position, and the clamshell incision, as you see, this transsternal bilateral thoracotomy. Here the surgeon is showing us the lungs and the heart. This is standard for all our bilateral transplants. Our lines, we use the same lines. We're quite standardized for this, for all our transplants. Just one large peripheral IV usually, and one radial artery line, a PA catheter, right internal jugular, and then we will place a 3-lumen CVP by some other access, usually subclavian, at the time of induction. We don't really need that intraoperatively. That's for post-op management, so they can get the PA catheter out as soon as possible post-op. Standard ASA monitors, TEE, most cases. Entropy, our version of BIS, cerebral oximetry, only if the patient's got an unusual cannulation, such as a peripheral VA ECMO pre-op, heating blankets. Airway management is simply left-sided double lumen tubes. Personally, if it's a left single lung transplant, I'll usually use a right-sided tube because I like using right-sided tubes. Most of my colleagues don't, and the surgeons are very comfortable even for left single lungs having a left-sided tube. They're just used to that anastomosis. And here we see the view through the bronchial lumen of a left-sided tube. Anesthetic, there's nothing particularly remarkable about the anesthetic. It would be whatever your version or the attending anesthesiologist version of an intravenous cardiac anesthetic, slightly modified. I'd probably mostly use ketamine, some propofol, opioid infusions, rocuronium, some midazolam. Most of us like to use sevoflurane as much as possible, particularly when the new lungs are in, because we think there is some anti-inflammatory effect to sevoflurane. Our vasopressors will have prepared at beginning or norepinephrine vasopressin. Other drugs, similar to what you heard for cardiac anesthesia, solumedrol, piptazo as an antibiotic, unless the patient has cystic fibrosis. In that case, the patient will have had a consult from infectious diseases preoperatively, and then we will go on their advice for the antibiotic choice. Now, during surgery, are we going to use no support? Are we going to do this off pump? Are we going to use ECMO? Or we're going to use cardiopulmonary bypass? Now, the answer to this question is very much in evolution. So this graph shows the use of ECMO, CPB, and no support at our hospital over the last, well, this is starting in 2012. So if you look at the dots on the far left of this graph, the gray line there and the gray dots, those are cases that were done off pump, as we used to say, okay? And 2/3 of patients were done without support. The orange bars there, those were patients that were done with cardiopulmonary bypass. So about 1/3, and then we started doing ECMO in 2012. So that's the blue dots. And if you follow the blue dots, you can see up to 2017, we're now getting to the period where about 2/3 of our cases are done on ECMO. And you see our use of cardiopulmonary bypass is down to almost nil. Cardiopulmonary bypass now for us is strictly the occasional case where there is some cardiac surgery at the same time, perhaps a valve replacement or repair at the same time of the lung transplant. Now, when we talk about ECMO, we're talking about central cannulation, basically always, for our purposes, elective central cannulation intraoperatively, so ascending aorta and right atrium. Standard, basically the same cannulation that you probably see for most of your cardiac cases. Now, we are not the center that really initially pushed ECMO in lung transplantation. That was Vienna. And this is several publications from different centers over the last 12 years now about their use of ECMO or cardiopulmonary bypass. So if you look at the top line, that's Vienna, they published 2007. Now, these are not randomized control studies. They'd already decided they wanted to use ECMO, and they're comparing the patients who had ECMO to historical controls who had their lung transplant with CPB. So the ECMO patients, the ICU stay 12 days versus 23, hospital stay 26 versus 51. The bottom line is our hospital, Toronto, we published 2015, ICU 5 days versus 10, and hospital stay 19 versus 27. So the surgeons at our hospital are great believers that with ECMO, less anticoagulation, less blood product transfusion, less graft rejection, and shorter hospital stay. They are very much believers of this now. Intraoperative fluids. Now, this is a picture of the Atacama Desert in Chile. I guess it's the driest spot in the world. I began doing lung transplants in 1989, and this represents our fluid management in 1989. We kept these patients as dry as possible. We knew that their outcome was better if they didn't go on cardiopulmonary bypass. We knew that all the lungs were poorly preserved at that time. So we were bound to have lung injury, and we just kept the patients as dry as possible to decrease the lung injury. And this is our representation of our fluid management. Currently, this is Iguazu Falls in Argentina. And as you can see, it's very, very wet. Now, I'm not saying that we flood our patients, but we no longer severely fluid restrict them because the lungs are simply better prepared, better preserved, and less prone to lung injury and graft dysfunction, and particularly with the use of ECMO versus cardiopulmonary bypass. So intraoperatively, I probably don't give more than 2 liters of crystalloids. And for volume, if I need volume and I don't need blood products, most of us use as a colloid albumin 5%, which we have actually readily available from our blood transfusion service. Blood products, as indicated. This is a look at 1 year recently of our lung transplant use of blood products. Packed red cells there on the left, 93 patients, 56%, 93 patients, 56% received red blood cells. So about half the patients, that's just in the operating room, about another half of those patients, again, will get blood transfusions post-operatively. Platelets, 19%, fresh frozen plasma, 32%. And our intraoperative transfusions are down with the use of ECMO versus cardiopulmonary bypass. These are our goals for blood management during ECMO. Hemoglobin 80 to 100, INR under 1.8, platelets over 80,000, fibrinogen over 1.5. And we just run the ACT between 160 and 200, which, as you know, is very different than cardiopulmonary bypass. Now, a big difference between ECMO and cardiopulmonary bypass is probably most of you, many of you, restrict your use of blood products while you're on pump. Okay, if you're on cardiopulmonary bypass, you hold off on your blood products, even though you're going to need them until you're off pump, so that the pump doesn't injure those platelets and other products you put in. That's not what we do with ECMO. During ECMO, we give products just as soon as they're needed. We do not fall behind. We do not wait till we come off to try and catch up. During the period of lung reperfusion, we do independent lung ventilation. We do this very simply, really. We just ambu bag the old lung and put the new lung onto a ventilator with air, low PEEP, and low pressures until for 10 minutes while the surgeon gradually reperfuse the new lung. We're always afraid of this picture as a new lung gets reperfused, and that's air. And you see this in cardiac. Air goes down the right coronary. You see inferior wall ischemia and transient hypotension. This requires an inotrope. This is really usually deal with this with just small boluses of epinephrine and temporize and occasionally open cardiac massage. If you're on ECMO, this isn't really a problem at all. We just wait it out. Now, some disease-specific things. Cystic fibrosis, basically cystic fibrosis is a 4-hour battle between the anesthesiologist and the secretions. We start with a single lumen tube, suction as best we can. We'll often take a half an hour with a big suction to get all the secretions out. I use what I call lung destructive ventilation with cystics. These lungs are going in the garbage, so I use high airway pressures, high tidal volumes. That's what they need to oxygenate them. It's very difficult to ventilate and oxygenate a cystic. Emphysema patients, big problem with emphysema is dynamic hyperinflation on induction, okay? Once you get past induction, emphysema patients are the easiest patients to manage. But this business about you have to decrease your tidal volumes and your airway pressures on induction, or you'll get hypotension because of dynamic hyperinflation. We just have to be so aware of that. Now, idiopathic pulmonary hypertension. This is the smallest of our 4 standard groups that we see for lung transplant. They're the most difficult to manage, both for us in the operating room and post-operatively. Now, here's a 38-year-old woman. She has idiopathic pulmonary hypertension. She's on sildenafil, macitentan, other drugs to decrease her pulmonary vascular resistance. Her PA preoperatively is basically systemic. It's 105/41. Now, here's the thing about this patient. Pre-induction, we do a blood gas, and we see that her PaCO2 is 29. Now, perhaps a third of patients with severe pulmonary hypertension are hyperventilators. This is so important because they are habituated to this CO2. This is the pulmonary vascular resistance, or the CO2 level that they need to decrease their PVR to optimize their cardiac output. And after induction, initially we have to return them to that CO2 intraoperatively. Very, very important to do that. If you don't, the RV starts to fail. Pulmonary hypertension, we're worried about hemodynamic collapse. We place the PA catheter pre-induction. We start our vasopressors pre-induction. Now, I want to tell you just for a couple of minutes about our management of pulmonary hypertension in lung transplant, because it's different than our management of pulmonary hypertension in cardiac cases. So step number 1 is increase the systemic vascular resistance. Pure vasopressors, okay? Norepinephrine vasopressin. Step 2 is decrease the pulmonary vascular resistance. Nitric oxide, again, we have it. It's quite easy for us to get in 10 minutes in the operating room. Here it is hooked up to our anesthetic circuit. If you don't have nitric oxide, there are inhaled options. Milrinone, or our inhaled option, is prostacyclin or Flolan. You see, there's a patient having 1 lung ventilation, and we've hooked up the Flolan in the yellow circle there into the anesthetic circuit. The one caveat about this is the glycine diluent for the Flolan. It precipitates in your HME filter, and that's what you see in the red circle. It tends to clog up very slowly, but it clogs up over an hour or 2 hours, your HME. So you just have to replace that every hour. Now, after we do that, we rule out other causes such as pH, PaCO2, and only then do we begin to introduce inotropes as needed for our cardiac index. But our first step is always get the systemic resistance up, and then get the PVR down in these patients. TEE during lung transplantation, if you read the literature, they'll tell you to do it in every patient. We are much more selective. Again, the literature says you need it for RV function. Now, if we hear on the left is a good RV, transgastric view by TEE, and on the right is a very poor RV. It's dilated, it's compressing the LV. Now, if you start out with a RV on the left and then it becomes the RV on the right, obviously the RV is suffering. But more often, when we first look, we see the RV on the right, and it's tough to tell if it's getting better or worse intraoperatively. So personally, I'm not that impressed with TEE as a minute-to-minute monitor of RV function. We still depend on PA pressure, but not PA pressure alone, PA pressure and cardiac index. We don't always use this continuous monitor, which you just saw for heart transplant, but we always measure the cardiac index, okay? We need to keep the cardiac index up. That is the most important thing. The RV is used to a high afterload, but the question is it suffering? And that's what your cardiac index tells you. The literature will tell you to always use TEE to look at the pulmonary venous anastomosis. Here on the left, there's a view of a TEE view of a left upper pulmonary vein pre-induction or pre-op, and then on the right is a stenosis post-op of the left upper pulmonary vein. The problem that we do this, and sometimes the surgeons ask us specifically to look at the pulmonary veins. The problem is how bad a stenosis is acceptable. Because what we found, our experience is that sometimes when you see a stenosis like the one on the right, and you tell this to the surgeon and you tell the surgeon they have to fix this, that when they try to fix this, they only make it worse because it was a difficult anastomosis to begin with, very difficult to fix. So often, if we have a stenosis like this on one side and the other side is fine, we'll, in discussion with the surgeons, we'll just leave that. Now, personally, I like using TEE, but mostly I like it for volume. When you're on ECMO, it's very difficult to know where you are with your volume status. And again, you see air right away rather than wait for inferior ischemia. Occasionally, you'll see RV dysfunction or other things with TEE. But honestly, to me, it's a really good monitor of volume. Now, where is any of this written down? Well, Andy Roscoe has written a very good chapter in Principles of Practice of Anesthesia for Thoracic Surgery 2 years ago. Our vasopressor management, it's not just us that does this. This second reference here is actually an article from San Diego about managing pulmonary thromboendarterectomy. Again, end-stage RV dysfunction related to lung disease. But it's interesting that their management is exactly the same as our management. So two different centers in kind of two different contexts have evolved the same way of managing RV dysfunction from pulmonary disease. So just to point that out, our patient, the 65-year-old woman, she was extubated post-op day 3. She did have multiple episodes of acute rejection requiring increased steroids. She was discharged from the ICU post-op day 5 and discharged from hospital after about 3 weeks. And here she is post-op. Now, I'd like to point out that the picture on the right was taken in January. The weather is not like this in Toronto. We don't have any snow right now. And that basically is the end of my summary. If we have a few minutes, I'm very happy to answer any questions.
Thank you, Dr. Slinger, for an excellent deliberation, as always, on the update on anesthesia for lung transplant. Shomi, I don't see any questions on the chat box. I would invite some of the experts on this area. I can see Dr. Kanchi Muralidhar, Dr. Suresh Rao. So if either Dr. Suresh or Dr. Muralidhar has some comments or questions, they would be more than happy. We'll be more than happy. Shomi, is that okay with
Yeah,
the
yeah,
time?
absolutely. We have time. I mean,
Yeah, I think it's a very good and excellent lecture. Coming to the ex vivo perfusion, if the PF ratio is less than 200, so what makes you think you can do it or not do it? Because you can have a poor PF ratio with infection, pneumonia, or you can have a poor PF ratio with because of the fluids congestion. So, do you have any preference when to do ex vivo, or it is in all cases you try?
You're very right. I didn't point this out. A poor PaO2 FiO2 ratio could be for a number of reasons, some of which are relatively simply treatable, such as if the patient has been overhydrated or is having a degree of LV dysfunction, and some of which are not treatable if the patient has an infection and pneumonia. So we also look at the chest x-rays and then look and take into account the patient's history. We'll do a bronchoscopy, we'll look at the secretions, we'll culture them. If it's an infectious process, then yes, we aren't even going to try. But if we do think it's a fluid situation or a problem with the patient, way the patient's ventilation has been management that is treatable, then we'll go ahead and try. And having said that, we're only successful about half the time.
Okay, that's good.
But there's definitely certain situations that we won't even try.
Okay, so the other thing is if you have a primary graft dysfunction, so when do you think ECMO continuation is required? If you think it has to be done, what kind of ECMO? VV ECMO or VA ECMO you prefer?
Okay. That's going to be very much a case-specific situation. We'll look after weaning ECMO, and then if it looks like the heart does not need any support, we'll look at the ECMO. If the heart looks good, if it looks like it's purely an oxygenation problem, then we'll probably initiate peripheral VV ECMO in the operating room. But if the heart is looking poorly, then we will change to peripheral VA ECMO. But we always try and make that decision before leaving the operating room.
Okay. The other question is pulmonary artery hypertension in the post-operative period is it can cause graft dysfunction. So do you have any limit on PA pressure? Your decision will be based on the PA pressure? Because with VV ECMO, your PA pressure may be high.
Absolutely, absolutely. And certainly if you've got a PA systolic over 60, that is going to invite primary graft dysfunction. So again, that will very much influence our decision in that case for VA ECMO to unload the lungs very much.
Okay, that's great.
Dr. Kanchi Muralidhar, sir, if you have any comments, questions, please do comment.
Thank you for inviting me. I was really listening with rapt attention. It was an excellent talk. Very clear and lucid. So I have, as of now, I don't have any questions. If there's any, I will get back to you soon. Thank you so much.
Thank you, sir. And so I think we will end our session on anesthesia for lung transplant. And once again, thank you, Dr. Slinger. Thank you, Pete, for taking your time and being with us. And hopefully see you soon face to face, either in this country or whenever I'm coming to visit my son in Toronto. See you soon.
Great. Well, it's wonderful to see you again. Thank you very much.
Thank you. Thank you.
Thank you, Dr. Slinger. Thank you, Dr. Shrikar Sringupta, for conducting that session. It was wonderful having Dr. Peter Slinger with us. It was a great, huge honor. to have such a stalwart in our forum. So moving on to the next lecture. The next lecture is on the topic of lung transplant to the COVID lungs. And for the same, may I please request the chairperson for the session, Dr. Rahul Govishwash, who is also our current president of the society. And he is a senior consultant cardiac anesthesiologist with Rabindranath Tagore Hospital. May I please request Dr. Rahul Govishwash to introduce our next speaker, Dr. Suresh Rao, who obviously does not need a real introduction. Everybody knows him. Dr. Rahul, please.
Thank you, Shomi. Yeah, as you are absolutely right, our next speaker really needs no introduction. However, as a part of this excellent academic program, I would still like to give a bit of introduction to him. Dr. Rao is a very senior cardiac anesthesiologist. He is the senior vice president of our National Society of Indian Association of Cardiothoracic Anesthesiologists. He is currently the co-director of the Institute of Heart and Lung Transplant and Mechanical Circulatory Support, and the HOD and senior consultant of cardiac anesthesia and cardiac critical care at MGM Hospital, Chennai. Today, he will be speaking on lung transplant in the COVID lungs. Dr. Rao, you may please begin your presentation. Thank you.
Yeah. Good evening, all. I hope you can hear me and see my slides.
Yes, perfectly.
Yeah. So it's a great pleasure to be here and also honored to speak next to Dr. Peter Slinger. So this is the institution MGM Healthcare, where we are offering services for the heart failure and respiratory failure. So this, I will outline my talk based on these headings. I will give you a brief introduction, look at the indications for lung transplantation in COVID-19 ARDS, and I will discuss some of the procedural and intraoperative considerations during the lung transplantation, and also some highlights on the postoperative management. Finally, I will share our own experience about the lung transplantation in COVID-19 situation. All of us have affected by the COVID-19. Majority of people, their livelihood or the lifestyle has been affected. And 80% of the patients who had COVID disease didn't have much symptoms or mild symptoms. 20% of the patients probably had moderate to severe symptoms requiring hospitalization. Maybe around 10% of the patients really developed respiratory failure, and some people would have got severe hypoxemia requiring endotracheal intubation and mechanical ventilation. So in such situations, the mortality rate is high, around 60%. Now, patients who are not responding to conventional mechanical ventilation may be candidates for ECMO, especially in institutions with the appropriate resources. And this can be used as a bridge to recovery or bridge to transplant. If you look at the statistics, around 18.5 crore people have been tested positive for corona. And we have seen around 40 lakh deaths all over the world. If you look at the Indian figures, more than 3 crores people have been reported as corona positive, and we have lost around 4 lakh people for this corona disease. Coming to the history of lung transplant, even though first human lung transplant was done by James Hardy in 1963, the first survival lung transplant was done by Bruce Reeds in 1981. The first successful double lung transplant was done by Joel D. Cooper in 1986. The first successful double lung transplantation for COVID-19 was done in 2020. Annually, around 5,000 lung transplants have been done all over the world. And we have done around 13 lung transplants for COVID-19 ARDS. So when will you consider lung transplant for COVID-19 ARDS? These are the criteria published in Lancet 2020. Age should be less than 65 years. Of course, we have done 2 patients beyond 65 years, one 67 and other one at 69 years. They have done well. So age is just a number. And of course, important thing is it should be a single organ dysfunction. Apart from the lung, all other organs should be in good shape. And you need to allow sufficient time on ECMO for the recovery of the lungs. If the lungs are not recovering probably after 1 month, 2 months, that is the time to do the lung transplant. And there should be a clear evidence of irreversible lung disease, such as bullous destruction or established fibrosis in CT. And patient also should be awake. So we usually don't paralyze, sedate patients on ECMO. So if they are paralyzed and sedated, there will be severe muscle weakness. The overall outcome will not be so good. So we keep them awake and also will give very less sedation. And we should be able to discuss about the transplantation with those patients. And otherwise, patients should fulfill all the standard criteria for a transplant. We also do the SARS-CoV-2 PCR. It should be negative for the deep respiratory tract sample. And the center should have substantial experience with high-risk ECMO as well as transplants. And also there should be easy access to donor pool. So what are the contraindications for lung transplantation? Recent malignancy. If the patient has got multi-organ dysfunction, which is possible when the patient is on ECMO, they should not have any active hepatitis B or C. Also, they should not have any chest wall deformities, should not have psychiatric illnesses, they should not be obese, and if they don't have social support or if they give history of substance abuse, probably they are not the candidates for lung transplant. So what are the challenges while doing lung transplant in patients with COVID-19 ARDS? As Dr. Amish pointed out, multiple blood transfusion can result in high HLA antibodies. So all these patients on ECMO would have received a lot of transfusions so that their antibody levels may be high. Again, the other thing is we will not be able to do the complete evaluation. For example, one patient had coronary artery disease, but the patient is on ECMO and doing a coronary angiogram. All those things are very difficult tasks. So we don't do the right heart study also in these patients. Infection, again, they may have recurrent infections on ECMO. Basically, the lung is the source of infection. And unless you take out the lung, we may not be able to treat the infection fully. And they also will have coagulation abnormalities, especially beyond 1 month. They may have thrombocytopenia and there may be thrombolysis. So many things can happen in these patients. Also, these patients will have more blood loss while doing the transplant. Again, timely availability of the organ is a big question mark, because after 1 month of ECMO, you'll decide to do transplant, but another 1 month you may not get any lung. So how will you manage these patients? And of course, finally, doing any transplants during the COVID-19 pandemic as such is a challenge. So what are the criteria to accept the donor? So the donor age should be less than 55 years. And usually we do the ABO compatible transplantation. The X-ray should be clear. PF ratio should be more than 300. The tobacco history should be less than 20 pack years. There should not be any evidence of aspiration. Patient should not give any history of cardiopulmonary bypass or thoracic surgery, because the lung harvesting will be very difficult if it has got adhesions, and bronchoscopy, it should not reveal any purulent secretions. Now, in what is special about COVID-19, you also have to assess the COVID-19 disease in the donor. So all the patients, we do the RT-PCR from the deep sample, that is basically from the ball, and it should be negative within 24 hours, and CT should be normal. Suppose if the donor gives history of exposure to COVID-19, so at least 1 week should have been passed before harvesting the organ, and RT-PCR should be negative, HRCT should be within normal limits. What about a donor who had COVID infection before? Again, at least 21 days should have been passed. There should be a complete clinical resolution of the infection. HRCT should be normal. RT-PCR should be negative. Then only you can accept the donor lung. Now coming to the perioperative considerations. Yeah, patients on ECMO for a month, obviously he'll be on a tracheostomy tube. So while doing the lung transplant, we will change the tracheostomy tube to endotracheal tube. This is because while doing bronchoscopy, through the endotracheal tube will be easier compared to tracheostomy tube. The other thing is, as Peter Slinger pointed out, you need to monitor the PA pressure in the immediate post-transplant period. But how will you monitor? Because inserting the PA catheter in these patients who are already on ECMO will be little challenging, because the right IJV, the return cannula will be inserted in most of the VV ECMO. So usually we use the left interjugular vein to insert the PA catheters. So sometimes manipulating the PA into the PA catheter into the PA may be challenging. The other thing is, as again Peter Singer pointed out, it is done on ECMO. Now, usually we will convert VV ECMO to VA ECMO or VVA ECMO. So we'll use both the femoral cannula and the IJV cannula as drainage cannula, and we will insert a cannula into the aorta. So it will be VVA ECMO. Finally, surgeons will use a pulmonary artery vent. Otherwise, while clamping the pulmonary artery, the PA pressure may go up. There may be RV dysfunction. So PA vent insertion, which is attached to the drainage tubings of the ECMO circuit. Again, you need to minimize the blood loss. So self-saver, blood product transfusion. So you can use the self-saver. Proper coagulation management is very important, because all these patients will have some kind of coagulation abnormalities, and donning and doffing of the PP should be properly monitored. So in lung transplantation, it is most of the time it is clamshell, especially these are all bilateral lung transplants. And that is the surgeon is preparing the pulmonary vein for the anastomosis. Usually, surgeons usually do 3 anastomosis. The first one is the bronchial anastomosis, next the PA anastomosis, and finally the pulmonary venous anastomosis. So in the immediate post-transplant period, first we need to do a bronchoscopy so that the bronchial anastomosis is patent, so that there is no bronchial anastomotic narrowing. Then TE, again, we routinely use TE. This is to look at the, assess the pulmonary venous anastomosis as well as RV function, and also to prevent any air in the heart chambers. We need to manage the bleeding and fluid management. Again, as Dr. Peter pointed out, we need to use restrictive fluid management. And ventilatory strategy, again, we need to use protective ventilation with less FiO2. And you have to prevent pulmonary artery hypertension and right ventricular dysfunction. Nitric oxide, we routinely use. Some are responders, some are not. And again, we should be ready to manage the primary graft dysfunction. Sometimes we may have to continue the ECMO in the immediate post-op period for 48 to 72 hours. What about the immunosuppression? Generally, we don't use interleukin-2 receptor blockers in patients with COVID-19 ARDS because they are already immunosuppressed. So we don't want to exacerbate the infections. So we use methylprednisolone intraoperatively and in the post-op period mycophenolate and tacrolimus if the renal function is good. Coming to our own experience with lung transplantation for COVID-19 patients, so far we have done 13 lung transplants for post-COVID ARDS. In fact, today we just finished the 14th bilateral lung transplants. All the patients were on ECMO. I think 10 patients on VV ECMO, 2 on VA ECMO. ECMO duration ranged from 29 days to 70 days. We had immediate mortality of two late deaths. 6 people were discharged. 3 people are in the ICU recovering. I'll just start with one case, 49-year-old male, resident of Delhi, known hypertensive. He was admitted with complaints of fever, breathlessness. He was tested positive on 8th June. Because he developed breathlessness, oxygen mask was tried, non-invasive ventilation was tried, prone positioning was also tried and failed. Finally, he got intubated because of the hypoxia. And a few days of ventilation, they tried to extubate him, but he developed again hypoxia, so he was reintubated. Finally, tracheostomy was done on 30th June. He became COVID negative on 24th June, but the CT chest was done, which showed extensive bilateral ground glass opacities, and he was ventilatory dependent, so they could not wean off the ventilator. Finally, he was airlifted to our center for further management. While receiving, we did the CT chest, which showed extensive bullous destruction, honeycombing, and consolidation. This is the CT chest, which showed extensive damage of the lungs. And after admission, his lung compliance worsened. So saturation started coming down. So we put him on venovenous ECMO. We used 17 French IJV return cannula and 23 French femoral venous access cannula. So initially it looked like lung compliance improved, but we tried to wean off the ECMO, we couldn't. We repeated the CT chest, which showed extensive fibrosis. There was no radiological improvement. In fact, it has worsened. So finally, we counseled the family for lung transplant and also registered in the government transplant registry. We continued ECMO as a bridge to transplant. So this is a patient on ECMO. We kept him on ECMO for a month. Finally, we decided to do the transplant, and we got a suitable lung on 28th August. So we did the transplant on VV ECMO, and we could wean off the ECMO in the immediate post-transplant period as the lungs were functioning normally. We could wean off the ventilator next day and put him on TPs. But a lot of task, complex procedure. We always monitor the BIS because these patients sometimes we try to give less sedation because they are vasodilated, blood pressure may be low. They also may have blood loss, so we use the cell saver. Again, we use the transthoracic echo just to look at the right ventricular function and to rule out any air. And we also do the bronchoscopy on the donor lung before the transplantation and also bronchoscopy after the transplantation to make sure that the anastomosis is all right. And also, even though it is done on ECMO, We also keep the CPB machine ready in case you need to go on bypass. So you can see the bronchial anastomosis here, that is done first, then the pulmonary artery, pulmonary vein. This is the explanted lung. It is totally destroyed. Somewhere it is hepatization of the lung. We also did the histopathological study of the explanted lung. We could see a lot of microhemorrhages, neutrophil infiltration, lot of collagen fibrin deposition indicating fibrosis, and also loss of alveolar sacs and no air in the lungs also. We also got electron microscopic study, in fact, which showed damage to the type 2 pneumocytes and the disruption of the vasculature in the endothelial lining, a lot of interstitial collagen and fibers, and mitochondrial damage indicated by the evacuation of the loss of cristae. So all these indicative of extensive damage of the lungs. So this patient, we could make him sit on a tracheostomy with TPs. This is the post-transplant X-ray. We usually do the bronchoscopy on a daily basis, sometimes once in 2-3 days, to make sure that the bronchus, bronchial anastomosis all are patent and also clean, healthy. This patient actually was very, critically ill patient. He could not even move fingers. So we had to give a lot of physiotherapy for the hands and also legs. We use the Lato machine to give physiotherapy to the legs. Patient can do it actively. If he is not doing, the machine will take over. So it will be a graded physiotherapy. And after 1 month of extensive physiotherapy, we could take him out. And after 6 weeks, we could make him walk also. We also published our results. In fact, this is a paper of international experience of first national lung transplants. So we are the co-authors. I think apart from US, Canada, our country, one more country was involved in publishing this paper in the Journal of Heart and Lung Transplantation. We also presented our data, the first 4 lung transplants for COVID-19 in the ISHLT meeting 2021 Toronto. So out of 4 patients, 3 were on VV ECMO, 1 was on VA ECMO. And the VA ECMO patient also had coronary stenting. So in all patients, we could wean off the ECMO after the transplant. 2 patients immediately on the table, 2 patients in the post-transplant period in the ICU. However, 1 patient developed Elizabeth meningoseptic shock, that is the VA ECMO patient. We lost him. All other 3 patients survived. This is again published in the Journal of Heart and Lung Transplantation. This is another paper by Gok et al. They published 2 cases, both survived, one at 68 days, one at 30 days, doing well at the time of publishing. This is another gentleman, 67-year-old, in fact, cabinet minister of one of the state of Jharkhand, who had severe COVID-19 ARDS. In fact, our team went to Ranchi, put him on ECMO, then airlifted to MGM. We waited on ECMO for 40 days. His lungs did not recover. Then finally, we did bilateral lung transplant. And this is after 6 months when he went back to his Ranchi. The CM received him and he's doing well. His lungs are functioning well. So doing lung transplant on patients with COVID ARDS is one thing. At the same time, doing lung transplants during the COVID-19 pandemic is also challenging because there is a risk of COVID transmission from the donor to the recipient, risk of COVID-19 from the healthcare workers to the recipient, and also surgeons may have to work with PPE. It is not easy to do the surgeries with PPEs. And also there is risk of healthcare workers getting the COVID-19. So this particular child had a severe lung disease, fibrosing alveolitis, diagnosed at the age of 2 months. So he was put on ventilator. At the age of 6 months, they did the tracheostomy, Russian boy. The Russian doctors referred to us. So he was with us on a ventilator for 4 years. And fortunately, we got a lung during the COVID-19 pandemic. So we went ahead and did the transplant, and he has recovered. But you can see him interacting with the surgeons. It's not an easy task, but again, it's a lot of work. So thank you all for your patient listening. I'll be happy if you have any questions.
Thank you so much, Dr. Rao. As always, an excellent and detailed presentation. I have one question for you. I'm very happy that you mentioned this 4-year-old child who just underwent a bilateral lung transplantation. And you are one of the very few centers in the world to do adult and pediatric lung transplantations. You have a significant experience in that. So as an anesthesiologist, as a cardiothoracic anesthesiologist, I would like to ask from you, in brief, what would be the unique challenges of lung transplant in the pediatric population? Are there anything specific which are a little different from the adult subset?
Yeah, the first thing is usually in all the lung transplant, we do the bronchoscopy, and in the immediate period, we need to assess the bronchial anastomosis. So negotiating the bronchoscope through the endotracheal tube, it is a challenge because in adults, it is easy. You have a bigger tube and smaller bronchoscope. But in pediatric, you need to negotiate. So you need to be very careful. We'll try to put a larger tube, as large as possible. That is one challenge. The second thing is monitoring the pulmonary artery pressure. So ideally, you need to monitor the pulmonary artery pressure in the immediate transplant period. In fact, while doing the one lung, other lung also you need to perfuse. But if the PA pressures are high, it may result in graft dysfunction. So in adults, you can put a PA catheters easily, but in pediatric, it's not so easy. The third thing is it's not about cardiac anesthesiologists. I'm talking about the team as such. It is easy to put a small lung into a bigger cavity. It is difficult to put a bigger lung into a smaller cavity. So when you are doing a pediatric patient, if the donor is little bigger, then it's always a challenge to insert those lungs. And also while closing the chest, they can have some kind of hemodynamic compromise also. And finally, again, bleeding, the blood transfusion is most dangerous or things in lung transplantation. So you need to try to reduce the blood loss. So pediatric, even small amount of blood loss will be a significant blood loss. So I think these are the major challenges. Apart from in the immediate post-op period, again, post-extubation, doing a bronchoscopy is not easy. In adults, you extubate next day, but the pulmonologist will come and do the bronchoscopy on regular basis. They just need some sedation. But in children, it's not so easy. You may have to give a full sedation. Again, daily sedating these children, it's difficult. And finally, the bronchial biopsy also, again, in adults, we don't need to anesthetize these patients, but in children, you have to anesthetize these patients.
Thank you. Yes, that was quite comprehensive. Coming back to the issue of pulmonary artery pressures, yes, we can't float a PA catheter. So one of the ways would be to use a needle. and measure it, transduce it. Echocardiography in any way plays a significant role in these children for chamber pressures and PA pressures.
Yeah, see, the TE may be useful, but not in, again, you need to have the pediatric TE. If there is a TR, probably you can assess the PA pressure, but they may not have any TR, no PR. So assessing the PA pressure sometimes may not be that easy or may not be that accurate. Then looking at the RV function, yes, it is useful. So the other issue is, again, dearing, it is useful. But assessing the PA pressure, what we do is we will usually put a PA vent. So it will have a side down. So we put a cob line into the PA vent and clamp the PA vent on the other side distal to the cob line and monitor the PA in the immediate post-transplant period. We'll try to keep the PA pressure around 25 mean or less. And once we come off fully and doing well, slowly, if the PA pressures are less, we'll take off the cob line and the PA vent.
Fantastic, fantastic. I would ask the audience now if they have any questions on this particular topic.
Rahul, can I ask a question?
Yeah,
Sure.
please go ahead. Please go ahead, Deepanjan.
Good evening, Dr. Rao.
Good evening.
It was quite enlightening to listen to you. Sir, what we find that many of these patients are on prolonged ECMO. Some are more than 1 month, 35 days, 40 days. And the recovery that we see in these patients is comes at the last 7 days. They start to recover and they quickly, within 7 to 10 days, they are off ECMO.
Yeah.
So we are very much, initially we are very much hesitant to think about transplant. We start to wait for the transplant recovery to take place. So what is the right time when you should be starting thinking of transplant rather than a primary recovery?
Yeah, I think it's a very good question and very complex also, not easy to answer. But what we do is we will repeat the CT after 2 weeks if it's not improving. So there are no signs of improvement. We'll do a CT and see. If the CT is same, because the ground glass appearance, those lungs can recover. But if the CT shows honeycombing, bullous destruction, those lungs are unlikely to recover. So after 15 days, we see some irreversible changes, then we will list them, but we'll still wait because to get a lung, it will take 1 month or 2 months. So after 15 days, probably we'll have some idea. But after 1 month, we will be actively looking at lungs if the lungs are not showing any signs of improvement. And obviously, after 40 days, if it starts showing improvement and there is a donor available, we will not go ahead with the lung transplantation. But if it is not improving or if it is worsening, then we tend to transplant them. But usually it is beyond 1 month, never before 1 month.
Thank you, sir. So these patients, they sometimes show a recovery and then again they have a pneumosepsis, a secondary infection, and then the lungs totally become wiped out. That's a problem we face on a regular basis. It's a very big problem that we are facing.
Yeah. I do agree.
So once they are safety, so go ahead, sir.
Yeah, I do agree with you because we had one patient who was on ECMO for a month. Finally, we could wean off the ECMO. We removed the ECMO. He was doing well. We started weaning off the ventilation. He was on CPAP, finally TP. Suddenly he deteriorated. And his SATs went down to 60. So we didn't know what to do. We put him back on ECMO. He was back on ECMO for another 10 days. Then we could wean off the ECMO, and finally he's in the ward now, ready to get discharged. So these things do happen. And lung is, as I said earlier, lung is the source of infection. So even though you treat the blood, the lung keeps giving infection and recurrent infections.
Thank you, sir.
Thank you, Dr. Rao. Is there any other question from the audience? We can take one more if there's any more question. Okay. Okay.
Yeah. Thank you.
Thank you so much. And we will go to the next session. And the next speaker for today's IACTA West Bengal Annual State Conference web meet is another person who needs no introduction. Our books on perioperative transesophageal echocardiography are standard texts for postdoctoral students of cardiac anesthesia and practicing cardiac anesthesiologists in India. She is the professor of anesthesia at Toronto University and staff anesthesiologist at Toronto General Hospital. As you must have guessed correctly by now, our faculty in the next session is Dr. Annette Vegas. Tonight, she'll be talking on ventricular assist devices. Dr. Annette, you may please begin your presentation.
Thank you, Raul and Dr. Das, for the kind invitation to speak today. I'm glad you were able to put the meeting together. I must confess, I was on call last night, so I'm a bit sleep deprived, and I actually had pre-recorded my talk. So once I share my screen, it'll be a video. I can't seem to share my screen.
We are seeing something here, Annette. Yeah, it's coming.
Okay.
We can see
Okay.
it.
So you guys must be playing it because I'm not playing it from my end.
Yes, we are doing it for you.
Okay, perfect. Excellent. Even better. Thanks very much.
We will wait for the presentation to finish, then we'll come back to you for the questions and answers.
Absolutely. Sounds great.
Dr. Shomi, if you can start the presentation, please.
I'm not hearing any sound on my end.
Yeah, it's the same with me. Dr. Shomi, we are not.
Yes. Actually, Dr. Verma, I think he's playing it. Dr. Verma, we are not able to hear any sound.
Yeah, in that case, we'll just go back to the first slide and restart.
Restart.
Raul, do you just want me to play? Do you just want me to play it from my end?
That's what
1 minute, Annette. Just let us see once. Yeah.
Greetings and welcome. My name is Annette Vegas, and I am an anesthesiologist from
Yeah,
Toronto,
we can
Canada.
hear it now.
It's playing, yeah.
Thank you to the
Just
organizing
increase the
committee
sound
for
a
the kind
bit,
invitation
if you can.
to speak today on the topic of VADs, what we need to know.
Raul, this is maximum sound. If madam wants to
This talk
do
will
herself,
focus on
we can.
durable ventricular assist devices, examining the what, when,
Ashok,
why, and how of using them.
Just a moment.
This is a broad topic, and time
Ashok, just pause it once. I want to hear from others if this sound is all right or not. Otherwise, I will request
No,
Dr.
I think
Vegas
Dr. Rahul, I think that it's not really very audible. So if madam could present it from her side, and let's see how it sounds.
I totally agree with that.
Yeah.
Annette, can you present it from your side? Annette, can you hear us? Yeah, okay.
Greetings and welcome. My name is Annette Vegas, and I am an anesthesiologist from Toronto, Canada.
We can hear better.
This is better. Yeah.
For the kind invitation to speak today on the topic of VADS, what we need to know. This talk will focus on durable ventricular assist devices, examining the what, when, why, and how of using them. This is a broad topic, and time permits only a brief discussion of the history, indications, insertion, and anesthesia for VADS. I will expand on the role of the right ventricle and briefly touch on echocardiography for VADS. I have no conflict of interest. VADS fall under the umbrella of mechanical circulatory support. VADS are designed to provide partial or complete mechanical support by directing blood away from the failing ventricle and into the circulation, restoring end organ perfusion, either as a temporary bridge or permanent destination therapy. Factors determining device selection include which ventricle is supported, right, left, or both, pump site, intra or paracorporeal, flow, pulsatile or continuous, and duration of support, temporary or permanent. The innovation and development of VADS has spanned the globe, with successes claimed on the North American, European, and Asian continents. This represents an attempt to find a solution for heart failure by the brightest minds marrying technology and medicine. The current era of modern implantable durable VAD support began in the 1990s with the rapid evolution to smaller, more reliable devices. The first generation were pulsatile LVADs, including the implantable HeartMate and the paracorporeal Berlin X-Core pediatric device. The second generation implantable devices are small continuous flow axial pump devices, such as the HeartMate 2. Current third generation centrifugal devices are the Hardware HVAD and HeartMate 3 devices, which use magnetic levitation technology to provide continuous flow. An early mechanical support device was the extracorporeal centrifugal Biomedicus pump by Medtronic in the 1980s, consisting of a plastic cone and internal rotating cones or an impeller. The pump provided continuous flow of up to 10 liters per minute. The addition of an oxygenator created an ECMO circuit for full support of the patient. The device provided short-term support to one or both ventricles in the setting of post-cardiotomy shock as a bridge to recovery. First-generation LVADs such as the HeartMate, Thoratec, and NovaCore were pulsatile devices engineered to mimic the heart's pulsatile flow. These were bulky devices with common features of blood draining by an LV cannula, a pump with valves that provided asynchronous positive displacement of blood into an aortic cannula and the patient's systemic circulation. These devices served as a bridge to transplant, but unfortunately had many complications. The solution was the development of continuous flow LVADs with a simpler design, durability without valves, small size, and totally implantable to provide ventricular support. These devices provide systemic, non-pulsatile, continuous asynchronous flow independent of the native heart. This defies physiology, as organs now have continuous rather than pulsatile flow. Blood drains passively into the single chamber valveless pump, which rotates at a rapid rate, continuously circulating blood forward. The axial flow devices use a propeller screw design to push blood continuously forward parallel to the impeller. The centrifugal pumps use a rotating impeller with blood entering the device and exiting in a perpendicular orientation. The commonest continuous flow devices in North America are the HeartMate 2 axial flow and the HeartMate 3 and HeartWare HVAD centrifugal flow devices. All are small devices that provide up to 10-liter flow at variable speeds. The devices are all FDA approved as a bridge to transplant and destination treatment. The centrifugal devices require less anticoagulation and cause less hemolysis, thrombosis, and bleeding. The Momentum trial showed fewer complications with HeartMate 3 than the HeartMate 2. The HVAD marketed by Medtronic was recently withdrawn from the market. So what role do LVADs play in managing heart failure? Heart failure is a growing worldwide problem, with more complete data available for North America and Europe. In India, the prevalence of heart failure is estimated to be 0.3%, or 390 million people, or the entire population of the United States. LVAD therapy is increasing for the management of heart failure in North America, with 2,637 insertions in 2018. This is still the minority of heart failure patients. I am unaware of an Indian registry, so I am not sure of the number of LVADs implanted in India. Where does VAD therapy fit into the management of acute heart failure? Emerging data from North American registries support using standardized protocols focused on rapid diagnosis, early intervention, ongoing hemodynamic assessment in managing cardiogenic shock. Mechanical support may be used in the form of percutaneous devices and ECMO, which is beyond the scope of this talk. Importantly, durable VADs do not have an initial role in managing the crash and burn heart failure patients. VADs do have a role in managing chronic heart failure according to the American Heart Association guidelines. Temporary or permanent mechanical support comes before experimental treatment and hospice care in managing stage D heart failure. The goals of LVAD therapy fall into 5 categories. Bridge to transplant for those with irreversible left heart failure at imminent risk of death and a candidate for heart transplant. Patients wait 3 months after LVAD implantation prior to listing for heart transplantation. Destination therapy for chronic heart failure on optimal medical management, but not a candidate for transplantation. The other categories are bridge to candidacy in patients completing transplant workup, bridge to recovery, which is infrequent, and bridge to bridge, which substitutes short-term mechanical support for more durable devices. The Interagency Registry for Mechanically Assisted Circulatory Support, INTERMACS, is a North American registry established in 2005 that collects data about durable VAD patients. Routine assessment of the patient's status uses the INTERMACS profile 1 through 7, with a lower numerical value representing worse clinical condition. 2 additional modifiers include the use of temporary circulatory support devices in the hospital and frequent rehospitalizations for patients at home. The decision to implant a durable device is at level 3 or 4, where the balance between risks and benefits appears optimal and not in the sickest groups. The goal is to intervene in acute and chronic heart failure scenarios before the patient is in extremis. Acute scenarios include decompensated chronic heart failure and acute conditions such as ischemia, myocarditis, or failure to wean from cardiopulmonary bypass after high-risk procedures. In chronic heart failure, criteria include stage D refractory heart failure on maximal therapy, dependent on inotropes, showing progressive end organ dysfunction and deteriorating right ventricular dysfunction, but robust enough to tolerate the procedure. There is no universally accepted model for VAD candidacy, and acceptance involves discussion by a multidisciplinary panel of anesthesiologists, cardiologists, and cardiac surgeons who evaluate the patients on a case-by-case basis. The recent 2019 Intermax annual report shows changes over time, both in type and indications for device implantation. For the period 2008 to 2017, almost half of the implants were for destination treatment with axial flow devices. With a shift to centrifugal devices, these are increasingly serving as a bridge to transplantation. Contraindications to LVAD implantation are similar to those for heart transplantation and include those listed here. These include significant end organ dysfunction, ongoing infection, cancer, and poor social support. How do patients do after LVAD implantation? The yellow lines show poor patient survival from optimal medical management at 8% and pulsatile technology at 24% in randomized controlled trials. The smaller continuous flow pumps dramatically improved 2-year survival and quality of life to 58 to 76%. HeartMate 3 devices have a 2-year survival of 79%, which parallels that of heart transplantation at 82%. The 5-year survival with destination VADs is 41%, inferior to heart transplant at 72%. Adverse events, especially neurological events, continue to have a detrimental impact on the success of continuous flow LVAD support. Unfortunately, complications do occur with LVADs over time. The commonest is bleeding, initially from surgery and later GI bleeding from mucosal malformations. Infections from the driveline, and less commonly bacteremia, may cause device infections. RV dysfunction may be present, and we will speak about this in detail shortly. Other patient complications include renal failure and cerebral events. Device reliability now have fewer instances of pump thrombosis or device malfunction. Neurological dysfunction and multisystem organ dysfunction are the most common causes of death. Preoperative assessment of the patient notes the etiology of heart failure, presence of concomitant diseases such as diabetes and end organ function, history of arrhythmias and presence of an AICD, which will need to be deactivated, level of cardiac support from inotropes, vasodilators, and diuretics, duration of in situ lines, as these represent a risk for infection, and finally the coagulation status, as this may need to be reversed. Preoperative optimization aims to achieve the listed parameters. Inotropes and vasodilators may help to manage refractory heart failure and maintain adequate end organ perfusion. Invasive hemodynamic monitoring using a pulmonary artery catheter can help tailor medical management. Intravascular volume is reduced by diuresis or, if necessary, hemofiltration without compromising renal function. Short-term mechanical support, such as a left-sided support with an intra-aortic balloon pump, or right heart support with a percutaneous device. From a surgical perspective, LVAD insertion is commonly performed through a median sternotomy using cardiopulmonary bypass without an aortic cross-clamp. The device is placed in the left ventricular apex with a coring device and sewing ring. The outflow graft is anastomosed to the ascending aorta. A driveline exit site is created. The device is de-aired, the cardiopulmonary bypass flow decreased, and LVAD flow initiated. The patient is weaned from cardiopulmonary bypass. An alternative technique involves a lateral thoracotomy approach, initiation of femoral cardiopulmonary bypass, and placement of the device under cardiac fibrillation. This avoids the need for a redo median sternotomy. Specific anesthetic consideration for LVAD implantation are listed here, including the placement of defibrillation pads and AICD deactivation. Stable induction with ketamine, Versed, fentanyl, and neuromuscular blockade. TEE to assess pre-bypass and post-bypass findings. Cardiopulmonary bypass with full-dose heparin and antifibrinolytics. A short pump run during which planning for weaning focuses on RV support. Post-bypass heparin reversal with protamine. Bleeding is managed with blood products, pharmacotherapy, and a cell saver. Monitoring of RV function to avoid excess volume. TEE and patient hemodynamics guide optimal VAD flows with a goal of maintaining a mean arterial pressure of 60 to 80 millimeters of mercury. Axial or centrifugal VAD devices provide continuous asynchronous flow independent of the native heart. This gives a non-pulsatile arterial trace, pulsatile pulmonary artery, and central venous pressure traces from RV contraction. Rhythm is important to maintain LVAD preload. Non-invasive blood pressure monitoring often fails using automated devices and requires manual readings with sound representing the mean arterial pressure. In addition, each continuous flow device has a console that displays information related to VAD function. The HeartMate 3 is a numeric display, the HeartWare a graphic display. Immediate postoperative management involves optimizing VAD function. This relies on afterload reduction and an adequate preload through maintaining RV function. The target mean arterial pressure is 60 to 75 to maintain RV coronary perfusion pressure and optimize VAD performance. The rhythm often defaults to the patient's preoperative rhythm. The AICD is reactivated. A keyword is vigilance for elevated pulmonary artery pressures, RV dysfunction, and bleeding. All VADs require some combination of anticoagulation with warfarin and antiplatelet agents. Right ventricular dysfunction complicates 45% of left ventricular assist device insertions, determining LVAD outcome by contributing to operative mortality, postoperative morbidity and mortality, and ICU and hospital length of stay. RV failure post-LVAD implantation is complex, often relying on a combination of diagnostic criteria. Though risk factors and risk scores exist, RV failure remains challenging to predict and difficult to prevent. Aggressive treatment is often required, and mechanical support might be necessary. LVAD function has an unpredictable effect on right ventricular function. Activating the LVAD increases venous return to the right ventricle. Right ventricular diastolic compliance improves as the LVAD reduces left ventricular pressure, which decreases pulmonary capillary wedge pressure and shifts the intraventricular septum left. Global RV contractility may be impaired during LVAD support from changes in the intraventricular septal position and motion. When the LV is severely unloaded, the intraventricular septum will bulge significantly into the LV, jeopardizing efficient right ventricular contraction. The right ventricular free wall works harder and cannot compensate for the loss of septal function, causing fatigue, which further exhausts the RV. Maintaining normal septal position and function can compensate for the loss of right ventricular free wall function. Right ventricular assessment involves many parameters, though none is perfect. Invasive pressures are reliably obtained during right heart catheterization. Measures like pulmonary vascular resistance and transpulmonary gradient are familiar. Others are specific for heart failure and advanced therapy, such as the right ventricular stroke work index and the pulmonary artery pulsatility index, or PAPI. Patients without pulmonary hypertension are more likely to develop right ventricular failure and die after LVAD surgery. This likely reflects poor right ventricular contractility that is unable to overcome an elevated PVR. Fixed pulmonary hypertension requires preoperative assessment with pulmonary vasodilators. Low preoperative right ventricular performance, low PA pressures, or right ventricular stroke work index should suggest the need for RVAD BiVAD support. Preoperative risk factors for right ventricular failure post-LVAD include patient characteristics, preoperative need for support, hemodynamic parameters, biochemical markers, and echocardiographic measurements. Groups have tried to develop risk scores based on preoperative risk factors to identify LVAD candidates at risk for postoperative right ventricular failure and plan treatment. However, because of its multifactorial nature, postoperative right ventricular dysfunction remains difficult to predict in individual LVAD patients. Most are familiar with the management of right ventricular dysfunction. Meticulous attention to optimizing preload, afterload, and contractility in the perioperative period is crucial to prevent right ventricular failure in patients with pre-existing right ventricular dysfunction. This includes simple measures such as maintenance of normal sinus rhythm, adequate ventilation, temperature, acid-base balance, and prevention of coagulopathy. Intraoperative right ventricular failure may prevent weaning from cardiopulmonary bypass and necessitate additional mechanical support from a right ventricular assist device, or RVAD. There is no durable RVAD support, so support is usually an extracorporeal centromag device with right atrium to pulmonary artery cannula configuration. There are no specific criteria for RVAD implantation. Early RVAD implantation at the time of LVAD surgery improves survival to transplant compared to delayed insertion after 24 hours. Elective BiVAD implantation has better 1-year, long-term, and transplantation survival compared to emergent RVAD implantation for acute right ventricular failure post-LVAD. We are going to close by looking briefly at the role of echocardiography for VADs. TEE is essential during VAD implantation with specific roles pre and post implantation, as well as to differentiate complications in the postoperative setting. The critical pre-insertion TEE exam assesses for patent foraminovaly, aortic insufficiency, RV size and function. In addition, pre-existing conditions can complicate VAD insertion and require the surgeon to alter technique or address the specific finding as indicated. These are echocardiographic examples of some of the absolute conditions that must be identified prior to LVAD implantation. The presence of a patent foraminovalle after VAD activation may cause hypoxemia and paradoxical emboli. The presence of aortic insufficiency may create a LVAD loop in which LVAD output flows retrograde into the heart, filling the left ventricle and VAD, resulting in poor systemic circulation. The surgeon will have to address more than mild AI. As we have learned, right ventricular function is a key determinant of morbidity and mortality after LVAD implantation. Poor RV function with significant tricuspid regurgitation may require tricuspid valve repair or early consideration of an RVAD to prevent worsening RV function post-LVAD activation. TEE can importantly assess adequate device function, starting with identifying correct cannula positions. The LV cannula is the device inflow or patient outflow. We refer to it as the inflow cannula. Correct cannula positioning is centrally away from all LV walls, as seen in two orthogonal views, and directed towards the mitral valve. The aortic cannula is the device outflow cannula or patient inflow cannula. We refer to it as the outflow cannula. It is in an angulated position in the anterolateral ascending aorta. Color Doppler often demonstrates turbulent flow. Spectral Doppler can assess the velocities of flow in both cannula. Echocardiography in the post-bypass period initially looks at the device deairing and later reevaluates for PFO now that the left atrial pressure is reduced. The position of the interventricular septum helps determine the pump speed, as the aim is for a neutral septal position, allowing LV decompression and adequate right ventricular function. The amount of TR is assessed and noted. The aortic valve often remains closed, though it is desirable to set the pump speed to allow for intermittent valve opening to prevent valve thrombus formation. It is important to reassess for residual AI, as the presence of more than mild AI should be addressed at the time of the initial surgery. Many LVAD complications can be identified by echocardiography. A common and life-threatening condition is cardiac tamponade in the immediate postoperative period from bleeding and hematoma formation as shown here. Another is a suction event, where the constant pump speed tries to extract more blood than is available in the left ventricle. As a result, the left ventricular chamber collapses, obstructing left ventricular assist device inflow. The VAD flows drop, the mitral valve deforms, and the interventricular septum moving to the left compromises right ventricular function. Thank you very much, and it's now time for some discussion. Greetings and welcome. My name is Annette Bakis.
Thank you so much, Annette. As always, a very detailed discussion, and our students will be benefited extremely because of this presentation. I have one question for you. As the life expectancy after getting the LVAD is increasing more and more in the Western world, many of these patients will be coming back to the hospital for separate non-cardiac surgical interventions. It might be the interrogation of a GI bleed post-VAD, or it might be a frank abdominal surgery, which is required. Now, in a patient who has an LVAD, what would be your recommendations to an anesthesiologist who is attending this patient in the non-cardiac theater?
That's a great question and very topical. It really depends, I think, a little bit on the setting. So patients who are in a for coming for, say, endoscopy, which is a very common procedure in these patients because GI bleeding is one of the issues with these patients. Just a little bit of sedation is fine. The real challenge is to monitor hemodynamics in these patients, and often the goal is just to maintain VAD flow. And the idea here is to make sure the patient has enough preload, a stable rhythm, and actually a lower afterload. So if possible, maintaining a good mean arterial pressure. The problem is monitoring the mean arterial pressure. And the issue here is that automatic blood pressure cuffs don't frequently pick up the mean arterial pressure for you. So you have to do it manually with a cuff and a stethoscope and listen to return of sound. And that often reflects the mean arterial pressure. If they're coming to the operating room, you have a bit more leeway in terms of how you want to monitor your patient. Now, if it's a significant procedure, you may choose to put an arterial line in, which itself is very challenging because there's non-pulsatile flow. So certainly ultrasound is your friend in that situation. Or you can, again, use conscious sedation as much as possible and monitor mean arterial pressure as best you can. But really the goal there is to, as I say, maintain VAD flows as best you can.
Thank you so much. I will leave I will ask the audience now if they have any questions, particularly the students, because all of you who are going to the exams are frequently asked about the ventricular assist devices. And if you want to ask Dr. Annette Vegas any particular clarifications that you need regarding this mode of therapy.
I will say, Raul, are LVADs very common in India? Or, I mean, they're fairly common in Canada. We have a fair number of them. I don't know, I couldn't find any information about India.
Yes, I'll tell you, Annette, it depends on geographical locations of India as well. A few of the centers in the west and south have done a significant amount of ventricular assist devices to get a kind of a clinical experience. But there are other areas where cost is a big factor. And even with a subsidized kind of a package, patients will not be able to afford a ventricular assist device. So,
and are
yes.
the indications as destination or bridge to something?
Yeah, that's what I want to tell you. I don't think we have gathered that kind of experience where we can actually quantify it into a kind of a data to how the patients are being put in the pathway for heart failure management. How many of them are actually going to the destination, how many are going for bridge. So I think we need to wait for a few more years to build a substantial amount of data. And that is the reason why you couldn't find any kind of data to look into when you search for it for India.
Madam, I had a question, which is exactly the one you asked. Like in your center, what is your experience with, as in the indication for a LVAD placement, more of a bridge to transplant or more of a destination therapy?
Well, I think we're pretty much the norm. So as I showed from the literature, I think there's an increasing utilization of the centrifugal devices, which is the kind of devices we commonly use now. And most of them are going in as a bridge to transplant. I think earlier devices originally were intended mostly for destination therapy, but we're using them more and more as a bridge to transplant. You know, we have economic impact as well here. We're a socialized medical system in Canada. So, you know, not everybody can get an LVAD, and the people that do get LVADs are actually vetted quite substantially by a multidisciplinary committee with a goal to weighing risks and benefits as to whether they're really going to truly benefit from them. And I think the feeling is if we can get acute or chronic failure patients through to transplantation. That's the gold standard, as we've learned today from other speakers.
Thank you, ma'am. And madam, what is your experience with BIVADs?
Great question. So, you know, I was just in the ICU this week, and of course we had a BIVAD. So you know, we do them. They're certainly, the intention here is, if you know ahead of time that your patient is going to have significant right ventricular failure, we put them in from the get-go. Our results are actually interesting and probably a little bit more anecdotal than they are published from our perspective. But I think the younger the patient, the more likely they are to survive a BIVAD and get onto a transplantation. And we've had great success with a younger population. Where we haven't had as much success is patients who come for LVADs who then need an RVAD and maybe are older, have multi-organ dysfunction, don't have a lot of reserve. We really do impinge upon that reserve. And our sense is, you know, very different from, say, patients on VA ECMO. These are patients that are relying on their lungs to oxygenate for the most part, and we're relying on their right ventricle to get better. So they either get explanted, as we did this week in one patient, or they move on to transplantation.
Okay, thank you, ma'am. Dr. Rahul, if you have any questions or any other questions from the audience?
Yeah, I would just wait for anybody, someone else from the audience, if they want to ask Dr. Vegas any question.
It is a very rare occasion we have Dr. Vegas with us.
Yeah.
Thanks to COVID, it's a virtual meet and we get to have her.
Yeah.
No, but I guess some of them are very sympathetic to Annette actually having a night, post-night. So maybe they are not delaying this entire thing. And but thank you so much. Yeah,
you're more than welcome.
No,
thank you,
I know, but thank you so much for being with us and for this excellent presentation that you did. And I will now close this session and give over the microphone to our secretary and the scientific secretary to conclude today's session.
Thank you, Dr. Rahul. Thank you, Dr. Annette. And I'm deeply grateful to all the stalwarts who graced our forum today. So we have come to the end of day 2 and the final day of our virtual annual conference, the first ever by IACTWB. And to end it, I would like to announce the winners of the eco quiz session. So Dr. Verma, would you kindly do we have the quiz master with us? I don't think so.
No, we don't have him.
We don't have him.
No, you, Somi, Dr. Somi.
Okay, fine. So the winner, we had 6 participants, and the scorer, the person who has marked them, is the quiz master himself. So the winner, we have one winner, and would I announce the winner first or the runner-up first? Okay, let me take cues from public forums, and I would go with the announcing the runner-up first. It is Dr. Shayandeep Jana from Arantagore, and he is just short of 1 mark from the winning marks. And the winner for this time's eco quiz session is Dr. Devjani Shah. She is from IPGMER. A big round of applause for both of them. And in the next meet, where we actually get to meet in person, we are hoping to award them on that occasion. So with this, we have come to the end of our academic endeavor. Hope you have enjoyed and hope we have learned, and obviously we have learned a lot. So over to Dr. Verma to close today.
Hello, I just want to thanks Teleflex India for supporting us, and I will request our president, Dr. Rahul, to give the concluding remarks.
Thank you, Ashok. Well, it has been a wonderful endeavor from the executive committee of the state chapter of IACTA West Bengal. And this 2 days has been an absolute feast of academics for all of us who attend this program. Special thanks goes to you as the secretary and Dr. Shomi as the scientific secretary for pulling it together and giving us the opportunity to listen to very reputed faculty from across the world, including the honor to have Professor Peter Slinger and Professor Annette Vegas between us, among us, to listen to them. It has been a rare privilege, as also the wonderful faculty that we had yesterday and today who shared their experiences. I hope the students of cardiac anesthesia have benefited extremely from this exercise, and I look forward to meeting with all of you in the next edition of our meeting. Thank you so much.
Thank you all.